Let's continue the ascending tract. So now we're going to talk about the anterolateral ascending tract system. We already covered the dorsal ascending tract system. Now, your dorsal was more of a modern system and it carried fine touch and then your proprioception, sense of vibration, sense of position, and also two-point discrimination. So that was your entire dorsal system, right? And we covered its entire course. Now, talking about the ascending tract of the anterolateral system, which is more of a primitive system and it carries information which are more primitive. For example, the intimate sensations, then itching, tickling, and then very important pain and temperature, right? And most important, crude touch. Now, the crude touch that has a different, for example, now we are grouping interolateral together, right? So for the anterior system, that's for your crude touch, and the lateral system is for your pain and temperature pathway. The lateral is for your pain and temperature pathway, so do not forget that the lateral is for pain and temperature, and anterior is for the crude touch, even though we've grouped them together, but they have slightly different pathways. Receptors for pain and temperature, free nerve endings and thermal receptors, yes. Then pain pathway, it has two type of fibers, A, delta, and C. A is for the fast fibers because of high myelination, they're very fast. C are not myelinated, so they're slower. These are not very highly myelinated, but they're mildly myelinated, relatively more than the C type. Right? Fast pain, how do you classify it? Any pain that you can feel in zero point 0.1 seconds. Any pain that you feel in zero point 0.1 seconds, that's fast pain. Slow pain is pain that you feel in 1 second. Now, the pinprick, that's a fast pain, and throbbing, nauseous, burning pain, that's slow pain. Now, fast pain you usually feel on your skin. Slow pain you feel in your skin as well as deeper tissues. For fast pain, mechanical and thermal stimulus are there. For slow pain, you have mechanical, thermal, but you also have chemical stimulus. Now, any tissue injury, any sort of tissue injury will cause the pain. Now, let's first quickly look at the pathway. So first of all, this is your alpha delta nerve fiber, and this is C nerve fiber, which is slow, and this is the fast pain fiber. These come and they're going to these are the first order ganglion neuron. They're going to terminate in the dorsal gray horn. From here, the second order neuron will start in the dorsal gray horn, exactly where substantia gelatinosa. So this is very important. That the second order neuron cell body is present in substantia gelatinosa. In the dorsal ascending tract pathway, we studied that it doesn't terminate here. Instead, it directly goes and terminates at the nucleus. So this one is not going to terminate here. Instead, it will terminate at the substantia gelatinosa in the posterior dorsal gray horn itself. Now, when you talk about posterior dorsal gray horn itself, when you talk about uh, these tracts, what are these? For example, this is going to come here and it's going to terminate at the substantia gelatinosa. From here, you're going to have ascending and descending tracts. These are the ascending and descending branches of the nerve fibers. These are the ascending and descending branches of the nerve fibers. Which one? These nerve fibers are coming from the dorsal root ganglion and they are going to come to the tip of the posterior gray horn. Here, it's going to form ascending and descending branches, and these branches they're going to continue at different levels. So this is going to like go up and down till some extent of some segments. So this is known as tract of Lisseur, right? This is just just tract of Lisseur, right? So this tract of Lisseur is there. Now your second order so this was like extra information. Now your second order neuron is going to start from substantia gelatinosa and it's going to pass contralaterally to the contralateral white column. So contralateral white column. So this is like very important thing here, that here in your lateral, so right now we're covering the lateral tract, right? So in your lateral ascending tract, it's going to go to the contralateral white column, to the opposite side. And as you are like going up, so the nerve fibers are going to be added medially. So here the nerve fibers are being added medially. So the medial most, that's from the cervical region, and the lateral most, that's from the sacral region. So here the fibers are being added medially, there they're being added laterally. So this is also important piece of information, that here they're being added laterally. Remember that the new fibers are being added laterally. Why? Because this did not cross over. This was going in the ipsilateral white column only. So when you're going ipsilaterally, so obviously there's only one room where these can be added laterally. But if it crosses over contralateral, so then the nerve fibers are going to be added medially, right? And this one will also be here, and this one will also be here, right? So that's why they're being added here medially, right? And then what happens after this crossing over, it's going to go up and where's the proper diagram? Yes, it's going to go up. So this is a pain in temperature, contralateral. It's going to go up. Fibers are added on the laterally, and then it's going to go to the ventero-posterolateral nucleus, the same nucleus, ventero-posterolateral nucleus as was in the dorsal system. From here, this is going to terminate, and third order neuron is going to go to the posterior limb, and then its axons are going to fan out to the postcentral gyrus, the lower part of the postcentral gyrus in the cerebral cortex. Right, so this is it. And not just it, but even they're going to go to the cingulate gyrus and also insula. So these are the three ways in which the pain is percepted. One is going to go to the postcentral gyrus because it has close association with the past experiences and relationship. And insula for autonomic or from internal organs, the pain that's coming from internal organs, and cingulate gyrus, the emotional aspect of the pain. So the three ways in which it is going. Right, so this is your lateral spinothalamic tract. If you talk about anterior spinothalamic tract, so it's going to come here, and then again the substantia gelatinosa, and it's going to go to the contralateral white column, and then it's going to ascend, and again the fibers that are being added, they'll be added medially, right? So this is also anterior one, is also going to the contralateral white column. So again, it's going to cross very obliquely to the opposite side in the anterior gray column. So this is also contralateral. So these both were contralateral, right? So they're going to go contralateral white column, and the new fibers that are being added will also be added medially. And this now at the level of medulla oblongata, you'll notice that there'll be also a third tract, which is a spinotectal. So you have a lateral spinothalamic, anterior spinothalamic, and there'll also be a spinotectal tract, which ranges from spine to the tectum. Tectum is a part of your midbrain. Yeah, sorry. Yeah, tectum is a part of your midbrain. It's not drawn here, but it's a part of your midbrain. So this is responsible for spino-visual reflexes. For example, if there's a pin that's down and it pricks your foot, you're quickly gonna look downstairs, and you're gonna quickly look downwards, and you're gonna see that, okay, where is this pin or whatsoever. So this correlation of your head and then looking downwards because of that pain sensation, this is basically the spino-visual reflex. So these three together at the level of medulla oblongata, they'll be called spinal meniscus. What all three? These three colors, uh, pink, yellow, and orange. So lateral spinothalamic tract, anterior spinothalamic tract, and spinotectal tract. They together make spinal meniscus, right? So this is your spinal meniscus, and your anterior was for the crude touch, and the lateral was for the pain and temperature, right? These also went contralaterally, very simple. And this didn't go contralaterally, it went ipsilaterally, and new fibers are being added laterally, and here the new fibers are being added medially, right? So they're being added medially. Now the slow pain, its fibers, they go and they give innervation to the reticular formation. Reticular formation, I've already told you, it's a mixture of gray matter and white matter. It extends throughout the brainstem, and its function is that it's the main switch of the cerebral cortex. And cerebral, this controls various levels of your consciousness. So this is connected. So here it comes and it alerts the brain, and not just here, also at the interlaminar nuclei of the thalamus. So instead of going to the fast pain goes to the ventro-posterolateral nucleus of the thalamus, yes. But this slow pain fibers, they go to the reticular formation and the interlaminar nuclei of the thalamus. So this is your slow pain. Then now moving forward, at night your reticular formation is very like not responsive, and it's done its job for the entire day. Now it's not going to work, so your cerebral cortex will be off. That's the reason they tell you to study in the morning, because your reticular formation will be active. Now this is the gating theory. That means when you massage and you, or when you do acupuncture, this is acupuncture technique, or when you apply liniments. So what happens, so if you're giving any other stimulations other than that pain thing, so this is very important because this can reduce the pain. And what's the mechanism? Mechanism is that there are very important connected neurons, because when there's already pain, but action potential is also coming from other pathways or because of other stimulation. So that is going to stimulate the connected neurons, and connected neurons are going to produce an inhibitory neurotransmitter, and the pain will be reduced. Right? So basically, the gate of pain will be closed. And the analgesia system says that from these three structures, there will be descending pathways coming. One will be from the periventricular gray matter, which is in your diencephalon, and then periaqueductal gray matter, which is in your midbrain, and then midline nuclei raphe, which is also there in your medulla oblongata. I suppose it's in your brainstem. Yes, this is in your brainstem. So from these structures, this descending fibers will be coming, and they'll be releasing morphine-like substances, enkephalins and endorphins. These neurotransmitters, these are going to inhibit the pain. So there are two systems. One are One is the gating theory for this, and one is the analgesia system, which basically inhibit the pain. So this was a tract for lateral and anterolateral spinothalamic tracts. Done. Now moving forward, talking about the spinocerebellar. These are also the ascending tracts. Info comes from, again, these three things are going to bring the information. These are the receptors. Now you have cuneo-spinocerebellar. So we're starting with spinocerebellar, from spinum to the cerebellum. Dorsal, anterior, which is posterior and interior, and then cuneo. Anterior has a lot of mixing and mingling that you need to know. Dorsal is just straightforward, right? And cuneo you'll know. So cuneo, okay, starting off first of all with spinocerebellar. Why now spinocerebellar? Why not spinothalamic? Why aren't we going to thalamus? Thalamus is ultimately going to take the information to cortex. So that's when you are at your conscious level and you actually want the information to go to the conscious level. If you want the pain impulse or whatsoever impulse not to go at the conscious level, but just to go at an unconscious level, then that information will be transmitted to cerebellum. Now, dorsal spinocerebellar and anterior spinocerebellar. So, in your dorsal spinocerebellar, what happens is the first order neuron it comes, and this is its dorsal root ganglion. That's its ganglion, like the nerve body, the cell body, and then this terminates at the dorsal gray horn. From dorsal gray horn, it terminates where exactly at the nucleus of the clag. Then the second order neuron it initiates from there, and its axon moves to the ipsilateral white column, the ipsilateral lateral white column, and it's going to ascend. So it's going to move to the ipsilateral lateral white column, and it's going to ascend. And when it ascends, where does it go? It goes where the inferior cerebellar peduncle to the cerebellum. So this is your dorsal or posterior spinocerebellar tract. Dorsal, so inferior, you'll remember. So it comes from these three things, right? Golgi tendon organ, muscle spindles, and your pressure receptors. This is your first order neuron. It terminates at the dorsal nucleus of Clark. From here, second ipsilateral it goes, and it goes where the inferior cerebral peduncle. Then your anterior one, there's a lot of mixing and mingling. So this also comes, and this also goes to the dorsal Clark nucleus, but it goes to the contralateral lateral. So your anterior goes to the contralateral lateral uh, white column, and then it ascends. And when it ascends, it ultimately goes to through the superior cerebellar peduncle into the cerebellum. But here also it doesn't rest. It again goes back to the opposite cerebellum because it actually belonged to this cerebellum only, but there was crossing over here. So it was like, wait a minute, I need to cross over again and go to my actual cerebellum. So this was basically anterior. So contralateral lateral white column. This was ipsilateral white column, and then ascending, and Clark's nucleus, very important, right? So first order, second order, and then third order. And then you have cuneocerebellar spinocerebellar tract. Now this is basically accessory nucleus of cunate. This is for upper limb. So there we studied all of these. We're going, do not confuse accessory nucleus of cunate to the nucleus cuneatus. Nucleus cuneatus is for the dorsal ascending, dorsal column ascending pathway, right? So now we are talking about the accessory nucleus of cunate, or accessory cunate nucleus. That is basically in the cuneospinocerebellar tract. So this you need to study more. And if you want, I'll just read out from the book what it says, because this is not that important, but it's good to have extra information. That many fibers in the fasciculus cuneatus from the upper cervical and upper thoracic segments, having terminated on the second order neuron of the nucleus cuneatus, are relayed and travel as axons of the second order neurons to enter the cerebellum, the inferior cerebellar peduncle of the same side. This pathway is known as cuneocerebellar tract, and the fibers are known as posterior external arcuate fibers. The function is to convey information of the muscle joint sense to the cerebellum. So this conveys information of the muscle joint sense to the cerebellum. So it goes via the accessory nucleus of cunate. That's all you need to know. And further, these are the other accessory, you can say, ascending tracts. One is spinotectal pathway, Spino-olivary, and Spino-reticular. Spinotectal basically is again that spino-visual. Remember when you look down. So same, it goes here, but it goes contralaterally. And Spino-olivary also goes contralaterally. Spino-reticular is the only one that goes ipsilateral because it's so unproblematic. Spino-reticular one is going to go ipsilaterally, and it's going to go here, right? So very unproblematic. And this is to stimulate consciousness, because this is the on and off button for your cerebral cortex. But reticular formation is also there again when you talk about the pain impulses, but there it's going to go contralaterally, because lateral and anterior spinothalamic were going contralaterally. right? So lateral was going to the contralateral white column, anterior was going to the contralateral white column. Dorsal was going ipsilaterally, and the fibers were being added medially. Remember, the fibers were being added laterally, sorry. The fibers were being added laterally. Here, the fibers were being added medially, right? Because it's going contralaterally, so the fibers will be added medially. This is how you can learn. And here, what happens, this is in a different spino-reticular tract. Here, it's going ipsilateral, and rest are going contralateral. Spinotectal is going up to the level of tectum, which is in the midbrain and superior colliculus. So this is your spinovisual response. And then spino-olivary is going to go to the olives, which are in the midbrain, and this is for your spino-olivary response, which is for proprioception, right? And cuneatus information, like cutaneous information, sorry. And then you have the spino-reticular, which is going ipsilaterally. So that's it. These were your three tracks that you need to know.